Thank you very much for the opportunity to be here today via video. And today I will describe some of the new and exciting ways that we are using novel or direct oral anticoagulant medications. And as someone who practices in the field of thrombosis, it has really been a revolution in terms of the therapies we use to treat patients with venous as well as arterial thrombosis. We used to have two options, intravenous heparin and warfarin. And over the past 25 years, we now have added to our toolbox low molecular weight heparins that are injectable, as well as direct 10A and 2A inhibitors, parenteral and most recently oral options in this area. And this has revolutionized our management of patients with venous thrombosis from our original requirement of treating patients in hospital to now treating many patients as outpatients who have serious thrombosis. And this demonstrates for you 25 years ago, if I had a patient with a DVT, PE, or acute coronary syndrome, those patients had to be admitted to hospital and were started on an intravenous heparin infusion with a transition to warfarin targeting an INR of 2 to 3. And today, with the large randomized trials that have demonstrated the benefit of direct oral anticoagulants, our outpatient management of patients with thrombosis has changed pretty dramatically. So here in the slide, you will see a patient with a deep vein thrombosis on ultrasound. These patients could also have a pulmonary embolism shown on the CTPA. I see these patients in the emergency room and I can prescribe a direct oral anticoagulant and treat them as outpatients if their conditions are not too severe. Now, if we think about our memory from medical school of the coagulation cascade, we can see where these new medications operate. So in green, you will see the intravenous heparin affecting the 10A to 2A ratio, modification of unfractionated heparin to the low molecular weight heparins, again moving from intravenous requirement to subcutaneous treatment with low molecular weight heparins. And then we can look at the individual clotting factors that are impacted by parenteral and oral direct anticoagulants such as factor 2A or thrombin, so the direct thrombin inhibitors that have been tested and used either as intravenous or subcutaneous are argatroban, bivalirudin, and hiruridin, for example, and the oral inhibitor of thrombin being dabigatran that has been shown to be effective across a number of thrombotic conditions. We also see the parenteral factor 10A inhibitor with fondaparinux and its equivalents in terms of oral factor 10A inhibitors such as Rivaroxaban and apixaban. So it shows you that over the years with research, we have moved from inhibiting these clotting factors as a group, such as with warfarin, as well now we are using oral inhibitors of single factors or combinations of factors. And the conditions that we have Phase 3 randomized trials to help us treat with direct oral anticoagulants include deep vein thrombosis, pulmonary embolism, atrial fibrillation, coronary artery disease, peripheral artery disease, stroke prevention, cancer-associated thrombosis, and other venous thromboses. There are certain conditions where we do not use DOACs because randomized trials have demonstrated to us that in fact, we are not successful at preventing thrombosis. That would be the case of mechanical valves. In some conditions, we have best data showing that warfarin is the most effective, such as patients with LV thrombus. And other conditions, such as antiphospholipid antibodies, have actually had randomized trials comparing warfarin to DOACs, and warfarin appears to be more effective. So we need more research, perhaps with newer direct oral anticoagulants for these additional conditions for which we currently still use warfarin. Now, this is a busy slide, but shows you the most commonly used oral direct anticoagulants, which include dabigatran, rivaroxaban, apixaban, and edoxaban. And you can see the conditions for which we have good evidence that these medications are effective: atrial fib, venous thromboembolism, stroke, and more recently peripheral artery disease, which I'll come to in a moment. The evidence when we compare DOACs to warfarin, this is an example from atrial fibrillation, really show we have equal, if not slightly superior benefit of the DOACs in terms of reducing thrombotic events. Shown here is stroke and recurrent fatal stroke. In addition, the question is always, what about bleeding? And the real benefits of DOACs is that we see efficacy is there, but we also see reduced risk of severe or fatal bleeding, such as intracranial hemorrhage, across the board with these DOACs. So that is a really attractive feature of using the DOACs over warfarin. We do have reversal agents for some of the most commonly used DOACs. Shown here is rivaroxaban, which is a monoclonal antibody used in patients on dabigatran who have experienced life-threatening or severe bleeding. It's available in the United States, Canada, and Europe, as well. Andexanet alpha is being tested for use of factor 10A associated bleeding, also being shown to be efficacious, and approvals are currently there in the United States and Europe, and some randomized trials are still ongoing. We can use prothrombin cell concentrate if these agents are not used, but the efficacy of prothrombin cell concentrate is not as well demonstrated. Now, with peripheral artery disease, I'll draw your attention to two trials that have used 1/4 of a full dose of a DOAC, in this case rivaroxaban together with aspirin, demonstrating its efficacy in patients with PAD. And these trials have really shown that if we use an antithrombin agent, an anti-factor 10 agent, we can prevent the generation of thrombin, together with an antiplatelet agent prevents platelet activation. And when used together, we've shown in both the COMPASS and the Voyager trial that we can reduce major adverse cardiovascular events and major adverse limb events in patients with PAD. So this has really been a revolution in our management of patients with PAD. And now finally, the concluding slide will just demonstrate the real benefits of DOACs. They have changed our care such that we can manage severe thrombosis as outpatients. Bleeding appears to be lower with DOACs compared to warfarin. We do have reversal agents, and there are certain conditions we keep in mind where we can't use DOACs. More recently, low-dose DOACs, 1/4 of a full dose used together with aspirin, are effective in patients with chronic stable vascular disease. And we await future research and randomized trials for newer compounds, such as factor 11 inhibitors. Thank you very much. It's been a pleasure to be here.